So I'm very happy to welcome you all for this interdisciplinary forum, which has been started by our beloved HOD in for getting the academic interest in the PGs running. So I would like the PGs to make use of this interdisciplinary forum, and it is a forum which has been joined by many experts, and they will offer different perspectives to your approach. So this being the first discussion in the interdisciplinary forum, I'd like to welcome Dr. Satish sir, who is a consultant pediatric rheumatologist, professor of pediatrics in CMC Vellore, and sir has finished his MBBS in Tirunelveli Medical College. He is a batchmate of our HOD, and he has also finished MD DCH in CMC Vellore. And more importantly, he is a fellow in pediatric rheumatology as well as pediatric lupus. Did his fellowship in University of Toronto, and he is the one who has started the pediatric rheumatology in CMC Vellore. So such an expert and a legend in pediatric rheumatology as well as rheumatology, and he is an associate editor in the International Journal of Rheumatic. Sir, sir, இது சார் அப்படி இல்ல, இந்த போஸ்ட் கிராஜுவேட் தெரியணும் சார். ஸோ இட் மே பி அன் இன்ஸ்பிரேஷன் ஃபார் த அதர்ஸ். எனக்கே உங்க கரிக்குலம் பட்டை பார்த்தா கொஞ்சம் இன்ஸ்பிரேஷனாக தான் இருக்கு. Because I did have some interest in rheumatology. So Sir has special interest in pediatric lupus as well as juvenile juvenile idiopathic arthritis. And Sir is such an expert, that too from a premier institute in India, CMC Vellore. We welcome you, sir, for this IDF forum. And another person who is close to my heart, he was a student of myself, and very happy to introduce Dr. Bharani Dharan, who is a clinical hematology fellow in Tata Memorial Hospital, Kolkata. He has did his MBBS in our college. He is an alumni of our college. Did his MD pathology in MAMC, Delhi. He has worked in SGPH Lucknow as a consultant as well as senior resident, and as a registrar in Apollo Hospital in clinical hematology. He is also a member of Delhi Society of Hematology and has many publications in hematology, namely the leukemia and lymphomas. So we have such two grades in this kind of discussion. So I like to PGs, what kind of doubt or you can ask them, and they will be willing to clarify. And I'm happy to invite you both for this IDF, sir. Thank you. Over to sir.
Thank you, Registrar Dr. Arun Kumar. So, as you all know, that this interdisciplinary forum has been initiated to impart knowledge for the postgraduates over the cases which need a multidimensional approach, a multidisciplinary approach. So, most of the times, in medicine, a single case cannot be solved by a single physician. Sometimes it may need an opinion from hepatologist, hematologist, and rheumatologist. So, to have a holistic approach in any case, we have started this forum. So this is an introductory webinar, and as I told, I am proud to welcome my classmate and close friend, Dr. Satish Kumar, and my student and hematologist, Dr. Bharani Dharan, to this webinar. So let us start the webinar. So the PG will present the case, and if any of the PG is having any doubt, just raise the hand in the Zoom. So please follow Zoom etiquettes. So when you want to talk, please switch on your video, and when you are not talking, please switch off your audio. That is very important. Mute your audio. So over to the moderators, Dr. Satish Kumar and Dr. Bharani. And I welcome our final year postgraduate, Dr. Nayana Pillai, to present the case of Pancytopenia for evaluation. It is an interesting case which attracts multidimensional approach. Over to PG, Dr. Nayana.
Good evening, sir. Thank you, sir. Good evening,
yes,
sir.
Start. Yeah, start. You are audible.
Okay. Good evening, sir and ma'am. Today we are going to present the case of Pancytopenia. A 49-year-old male residing at Thoothukudi, belonging to lower socioeconomic class, according to modified Kupusami scale, came to Thyroid with chief complaints of yellowish discoloration of eyes and urine, breathing difficulty, and palpitation for 2 weeks. History of present illness: 49-year-old male patient, non-psychiatric disorder, Came with complaints of yellowish discoloration of eyes and urine since 2 weeks, insidious in onset, gradually progressive. History of breathlessness since 2 weeks, insidious in onset, NYHA class 2, gradually progressive, no orthopnea or PND, aggravation on exertion, relieved at rest. Associated with bilateral swelling of lower limbs, initially started in the ankle, progress to involve up to knees. History of palpitation since 2 weeks, aggravation on exertion, relieved by rest. Recurrent belching present. There is no pruritus or clay-colored stools or dark-colored urine. No history of fever with chills or significant weight loss. No history of chest pain, excessive sweating, syncope, orthopnea, or PND. No history of cough with expectoration. No abdominal pain, vomiting, loose stools, or abdominal distension. No bleeding manifestations. No history of recent drug intake. Native medication or toxin exposure. No history of burning maturation or decreased urine output. No history of skin rashes, joint pain, oral ulcers, or dry eyes. No complaints of limb weakness, sensory disturbances, gait disturbances, or bowel bladder. Past history, history of psychiatric illness for 2 years, not on treatment. No similar history in the past. No history of systemic hypertension, diabetes, ischemic heart disease, asthma, TB, epilepsy, or thyroid disorders. No history of previous blood transfusion. No surgical illness in the past. Family history, no history of jaundice or anemia runs in the family. Personal history, patient consumes vegan diet, normal bowel habits, normal sleep, poor appetite, no addictions. Sir, can I proceed to general examination?
Yeah, so now from the history, can you summarize and tell what are differential diagnoses you will consider when you see this patient for the first time? Can you summarize the history and tell us what are the differential we can have?
Sir, this is a 49-year-old male presented with anemic symptoms along with jaundice. My first differential which I can think of is hemolysis.
Hemolysis, okay. Hemolysis, jaundice is only there. Is there any anemia history-wise?
Yes,
Transfusion history?
Sir, no, patient has breathing difficulty and palpitations. Breathing difficulty was more on exertion, sir. Also, there is a bilateral pitting period edema, which can be due to high output cardiac failure also.
Okay, but because remember in hemolysis, anemia is predominant than jaundice. The complaint is purely jaundice here, correct? I agree that history-wise they didn't give the history, but no transfusion the last 2 weeks. If it is hemolysis for 2 weeks, by this time, a patient would have received at least 1 or 2 transfusions. What do you think, Barney? What do you think, Barney?
Sir, actually, can you go to the history of present illness once? We can go by one line so that we can decode why the symptoms was started. So you have explained the breathlessness was since 2 weeks. That explains the patient having the anemia, right? And along with the bilateral swelling of lower limb, that means patient having the high output cardiac well, as already was stated, and palpitations also because of the anemia. And what about the next? Go to the next slide. This explains all anemia, right? And next,
pedal edema,
so why you ask
due to jaundice also? The pedal edema could be due to jaundice. Anemia,
yeah,
yes.
Exactly, sir. So what is the relevance of asking for pruritus and clay-colored stools in this patient?
Sir, in hemolysis, there will be pigment stones will be there, sir. It can cause cholestatic jaundice, sir.
Okay.
Obstructive jaundice, sir.
So cholestatic jaundice is not hemolysis. When you talk about clay-colored stools, sir, it is cholestasis. Yeah.
Sir, in chronic hemolysis, there will be distant stones production, sir. It can obstruct the bile duct and causes obstructive jaundice, sir. To rule out the obstructive jaundice causes, I have asked for the pruritus and the clay-colored stools, sir.
Yes, agree. Clay-colored stools means it's obstructive jaundice due to cholestasis.
Yes, sir.
Hemolysis, we don't expect cholestatic jaundice. Unconjugated hyperbilirubinemia, that's what we expect in hemolysis, anemia with hemolysis. Okay.
Yeah. So next, if you see there is negative history of fever and abdominal pain. So already have told that is it's a pancytopenia approach. So if there is a fever, and what is the relevance of fever? What is the relevance of abdominal pain in the case of pancytopenia?
Sir, few with the chills and riders malaria infections related causes. If sepsis induced sepsis modes or malaria infections, infective causes to rule out infective causes of pancytopenia. Sir.
So from the history, there is no evidence of infection. One is
Yes.
ruled out. And second thing, abdominal pain, what it signifies in the aspect of pancytopenia.
Sir, hepatitis, abdominal causes of pancytopenia, hepatitis, cholangitis.
Is
Yes.
any other most important part is there? Any other most important significance?
Gastritis.
Abdominal fullness or abdominal pain, any other, you want to rule out any other thing?
Sir, mastocytosis.
Yeah, so from the patient. Yeah, for example, in the case of massive splenomegaly or any splenomegaly, patient might have some discomfort in the abdomen. And second thing, in the case of PNH, there may be an unsightful thrombosis, like portal venous thrombosis. So we can rule out that also, because sometimes patient might present with the cortical venous thrombosis or only isolated portal venous thrombosis. So from the history, we can clearly say it is not fitting towards any thrombotic events. Right? And what about the bleeding manifestation? How do you assess the bleeding in case of pancytopenia? Is there any separate tool for assessing the bleeding in the case of pancytopenia? Where do you check for bleeding? Generally, where do you check for bleeding, especially related to the pancytopenia?
Mucosal bleeding, sir.
Mucosal bleed, right? Or any petechial rashes or ecchymosis or any purpuric lesions, that is all signifies. And the main important point, drug intake. So whenever the patient land up with, while evaluating for pancytopenia, you have to ask the patient to bring all the medications what the patient has taken. Because sometimes what happened, the vitamin B12 tablets, it looks like a methotrexate tablets. Accidentally, the medical person will give the wrong tablets. The patient will consume those methotrexate tablets as a vitamin B12 tablets, and automatically patient will land up in a pancytopenia. So the most important point is you have to advise the patient what are all the recent medications they have taken. So we have seen just 1 week back, we have seen the case as a pancytopenia. We advise him to bring all the medications, and the patient has taken the methotrexate instead of the vitamin B12 tablets. So the drug history is very important, and ask the patient to bring all the medication. That itself give the entire diagnosis what we are exactly facing. So we can reduce all burden of investigation to the patient. That is very important, especially the drug intake is more important for any other thing. And what signifies skin rashes? Why do you ask about skin rashes, joint pain, oral ulcer, and dry eyes? What do you want to rule out from this history?
Sir, autoimmune diseases, autoimmune conditions causing pancytopenia, sir.
Yeah, what is the most common? What is the most common? How does SLE? What is the reason behind the pancytopenia in SLE? What exactly? Why it caused pancytopenia? So most of the referrals, we always land up with the Curie autoimmune myelofibrosis. So in the bone marrow, we find myelofibrosis. Then we have to rule out what exactly triggered for this myelofibrosis. So SLE also will cause secondary myelofibrosis in the bone marrow. That is one of the reason for bone marrow getting fibrous, because of the pancytopenia will be there. And what signifies the no complaints of limb weakness, sensory disturbances, gait disturbances? What signifies that?
Sir, other differential is ineffective erythropoiesis will be there, sir. The most common cause of ineffective erythropoiesis is vitamin B12 deficiency. To rule out that symptoms, the neurological symptoms of vitamin B12, I have asked these symptoms.
Yeah, so most of the time, especially in the case of vitamin B12 deficiency, initially the manifestation will be the weakness, or sometimes the patient present with isolated limb weakness, or sometimes the patient neurological deficit will present, actually simple neurological deficits or any posterior column deficits. So we have to rule out any psychiatric illness, because whenever the patients come, any psychiatric illness, especially northern areas or North Indian belts, because they're full of vegetarian diets. So first of all, we always do the vitamin B12 levels, because the most common upon region wise, you have mentioned about the residence and what is the place, that is also very important. So in the aspect, so we have to classify the diagnosis or whatever etiologies based upon the context where we are using, that is very important. So the psychiatric illness, limb weakness, that may explain the earlier manifestation of vitamin B12 deficiency. So that you have to interpret according to your area, the region and the population. That is very important. Next slide, please. So what about the psychiatric illness? What psychiatric illness the patient have?
Sir, actually, the patient has no record, sir. According to the attender, the patient has some psychosis type of disorder, sir. But by the time we saw the patient has insight. There is no symptoms suggestive of psychosis, sir. But the patient more in favor of depression, like, sir. And he's not on treatment for the past 2 years, sir. He
So
took
after
treatment for about 1 month something, sir. That's according to the attendance.
So after treatment of vitamin B12, did the patient has improved from the psychiatric illness?
Sir, the depression improved, sir. On follow-up, depression was improved, sir.
Okay. And more, is any family history of any other cytopenias in their family or any other? Did you ask about the family history?
Yes, sir. Yes, sir. Nothing was there, sir.
Okay. So why I asked this question? What is the relevance of asking pancytopenia or any cytopenia in the history, in the family history?
Sir, inherited causes of
Yeah, to rule out the bone marrow failure syndromes. Okay, that is one of the history is important. And you have mentioned it as a vegan diet. So what is the difference between the vegan diet and vegetarian diet?
the vitamin B12 sources more in animal sources, sir, like meat, egg, fish, and all, sir. The B12 sources is more in animal sources, sir.
So that means the vegan means they won't touch any animal products in any form. That is milk also they won't take, and curd also they won't take. But in vegetarian, they will take the milk products also. So this patient is a vegan diet. That means he never consumed any other milk products. That signifies a vegan diet. So the vegan and vegetarian is different, completely different, right? Yeah. Next slide, please. Next slide. So yeah, so what is the importance of blood transfusions, especially in the case of hematology?
Sir,
Why we are asking the blood transfusions?
Sir, one is previous anemic episodes. Any is there? That's one, sir. If any transfusion related infections, another, sir.
Okay, fine. So for example, you have to ask how many transfusions patient has received, and when is the first transfusion was started, and how many months he is taking the transfusions. That is, frequency is important. And what about the last blood transfusion? Because why it is important is, if you are taking the blood samples, so we are doing the bone marrow procedures or any interpretation, we always have the gap of 3 months, whatever, if you're sending for any samples for HPLCs, because in the case of hemolysis or hemolytic anemia, if you're sending for sample for HPLC to hemoglobinopathies, always there should be a gap of 120 days. So that's what the last blood transfusion is very important. For example, if the case fitting to have only the hemolytic anemia, this patient might have hemoglobin. In that context, actually, if you send the blood products within a 120 days, so we are interpreting the wrong report from the patient. That's what the interval between the sending the sample for hemoglobinopathy investigations, the transfusion should always be at 3 months, because the lifespan of RBC is 120 days. That's what that should be, the average of 120 days should be there. Otherwise, and second point is that the load, the ferritin, that is also very important. In the multiple transfusions, patient have a ferritin that may deposit organ, that may cause interorgan damage. So that is also one important. So because we have the chelation therapy, indication is ferritin is more than 1000. So this is very important for especially the how much histories of how many blood transfusion, that is most important history. And second thing is that I think there is no any these symptoms like weight loss and any other. Have you mentioned those things also, right?
Yes,
Loss
sir.
of appetite and loss of weight. So this is also clearly the malignancy part. So from the history, what I can understand is that there is anemia is there and jaundice is there, right? And any other significant history have you have asked any other history?
So, Naina, so Bharanidharan told, because you told the final diagnosis of pancytopenia, is taking
Yeah.
your and B12 deficiency. From the history, is there anything suggestive of pancytopenia? We don't know. So remember, in the exam, you should
Exactly.
approach the child from the symptom complex. Don't worry about the final diagnosis. This child, anything in the history suggestive of pancytopenia? Answer is no. There is no bleeding, no transfusion. This is only jaundice for 2 weeks with pedal edema. When you approach this child, you should approach what are the possibilities for this case to have jaundice for 2 weeks with pedal edema and exertional dyspnea. You think like that. Then going into, because we know the diagnosis at the end, I know B12 deficiency.
Exactly.
That's very easy. So don't, in the examiner, don't present like straightforward B12 deficiency. This child is not straightforward B12 deficiency. This child is not straightforward pancytopenia. This child has come only with jaundice for 2 weeks with pedal edema, exertional dyspnea. So what are the possibilities you can think of? Because pancytopenia, we don't know. That's in the investigation is going to come. So as of now, what do you think? History-wise.
Sir, I didn't hear you. Sir.
Sorry, Naina, what I'm asking is, this child from the history does not look like this child have pancytopenia. History-wise, this child has got jaundice and exertional dyspnea and pedal edema. 2 weeks history. No fever, correct?
Yes, sir.
So this child, does it fit into acute hepatitis or acute fulminant hepatic failure, where you can have pedal edema? Can they present like this? Only jaundice history. I am telling this child has got acute hepatitis due to various reasons. That's the reason you asked all this history, drug intake, all those things you asked for, correct toxin exposure, native medication, all to rule out acute hepatitis. Is that correct?
Yes, sir. Yes, sir.
Because pancytopenia is going to come at the investigation. History-wise, there is no pancytopenia in this child. I will put like this. This child has got acute hepatitis, anemia, because we are thinking this child has got, a patient has got exertional dyspnea. No transfusion history. If you think anemia
sir.
and jaundice, history-wise, what are differential diagnosis you think of? Acute history. Because fever is not there. If it is fever, very easy. Dengue, rickettsial, malaria, all you told. Tropical infections can have anemia, fever, jaundice, leptospirosis. Correct?
Yes, sir.
Acute fever. Suppose this child has got 2 weeks of fever, jaundice, anemia. I will think of dengue, rickettsial, malaria, leptospirosis. Because there is no fever, we are ruled out infections. Next possibility of acute jaundice, acute hepatitis, like 2 weeks history is, you think of any drug intake, psychiatric drugs, any drugs, you said no drugs. No native medications, you told. Could it be Wilson disease from the history?
Sir, the age of the patient is 49, sir. It is a atypical age for presentation, but considering the patient has previous neurological findings, we also
should
did
consider
that work
because
cases.
Wilson is the one which can present from asymptomatic hepatomegaly to acute, chronic, fulminant. Anything you cause liver, you can have Wilson disease.
Yes.
Okay, if anything Wilson disease, you should keep in the mind. Hemolytic anemia, because no transfusion, if the patient is having 2 weeks, by the time somebody will given transfusions. If it is a hemolytic anemia causing jaundice, anemia is predominant. Okay.
Yes.
Can B12 deficiency presence with jaundice alone? Somebody, as you were told vegan, we talked about vegan diet. Can B12 deficiency alone? Can I make a clinical diagnosis of this could be B12 deficiency with the history alone?
Yes, sir. It's possible, sir.
Possible, all in medicine is possible. When this child comes to your OPD, when you sit in the OPD. That's what the examiner we want. Examiner we want syndromic approach to this patient. We don't want the final diagnosis. We want syndromic approach. This child comes, I will think of Wilson disease because there's no fever ruled out. Malignancy, you said no weight loss, no night pain, no bleeding manifestations. We'll leave it that. Toxins, drugs, we ruled out. Any blood transfusion history, I will say, okay, chronic hepatitis B. Now coming with jaundice. Previous transfusion. We can think of that. This is what I think from the pediatric aspect. If this child is 20 years old or 18 years old, I will think from pediatric. I don't know about adult much. I can ask your HOD. Adult wise, anything else you can think of for this child, this patient.
Naina, enumerate the
Sir.
differential diagnosis.
Sir,
Sarah
liver
said-
disorders,
yeah, proceed.
liver disorders can be one differential diagnosis, sir. Ineffective erythropoiesis is another diagnosis, sir. Third is we can keep also hemolytic anemias also, sir. These are the three differential diagnoses.
So
which I-
hemolytic anemia, which
So-
hemolytic anemia will present at 49 years of age? Which hemolytic anemia presents at 49 years of age? Immune mediated, non-immune mediated?
Sir, non-immune mediated.
Mostly is going to be non-immune
Immune
means your thalassemia. That's what your usual presentation. Thalassemia, sickle cell anemia, those are the non-immune mediated. G6PD deficiency on all non-immune. When you talk about this age, somebody is coming with anemia with jaundice, now you should think of immune mediated.
Immune.
Immune mediated, SLE will come. That's why you ask skin rash, joint pain, oral ulcer, dry as accept. Okay,
What about the
non-immune
hematological malignancy? Hematological malignancy? Is there any possibility?
Any possibility?
Sir, this
Yeah,
overall history of
lymphomas.
present this overall history of present illness, as Sir told, is not fitting toward a complete pancytopenic picture, because
Yes.
at least there should be some fever or any abdominal pain, or to rule out all focus, like not responding to therapy. But the entire picture is not fitting toward the complete pancytopenia. That too in the
Yes.
context of 49-year female with a jaundice and things will never go things of any acute hemolytic, because hemolytic anemia is not at all most common in the 49-year male. Actually, maybe some other secondary factor that is triggering the
Yes.
hemolytic episode, but actually it is not fitting toward any other acute hemolytic anemia in the context of 49-year male.
So 49 years, we
So-
don't see the non-hemolytic, like non-immune cause, like your thalassemia, sickle cell
Exactly,
anemia,
sir.
which
Yeah,
we see in children. This age,
exactly.
autoimmune you should think of. Somebody comes with anemia and jaundice, we should think of autoimmune. But autoimmune again, anemia will be predominant thing, may need transfusion. The jaundice is secondary to, not a primary liver pathology. Okay.
Yes.
Malignancy, 49 years, no weight loss. I don't know, malignancy still can present only with the liver involvement. I'm not very many notes like a lymphoma, like thing more than leukemia, because this doesn't look like leukemia because there's no bleeding, no anemia
Exactly.
recurrent transmission. If it is malignancy, it should be a lymphoma obstructing some node, portal triad, obstructing and causing jaundice, and some mediastinal lymph nodes causing exertional dyspnea. It's usually going to be lymphoma than leukemia. These are the possibilities coming to my mind from the history alone.
Yes, sir. Yes, sir.
Another, any other possibility you can think of another from this patient, this history. Don't worry about the final diagnosis.
So from this generalized history, I cannot fit into a complete clue what exactly the patient is having actually, because all things are negative history is there. No cough or there is no evidence of lymphoma, like there is no B symptoms, no any weight loss. There is no going toward a complete malignancy part is also not fitting towards that.
So,
As such, hematological cause is very simple. Just only 6 or 7 is the most common cause in this fitting, but not at all any fitting to any of the hematological cause from this history. actually.
the family is, if it is Wilson disease, what history you should ask in the family history? If it is Wilson disease presenting with jaundice, what family history you should ask specifically for Wilson disease?
Psychiatric illnesses in the family.
Huh? So start with consanguinity. Is there consanguineous parents? If this patient's parents are consanguinity. Why consanguinity important? Wilson disease is autosomal recessive, correct?
Yes.
Wilson disease, autosomal recessive, runs in the consanguinity, especially when somebody is coming from southern part of Tamil Nadu, a lot of consanguinity happens. And
Yes.
anybody in the family died of jaundice, unexplained jaundice in any age group.
Yes.
Second decade, we can ask about neurological symptoms. Usually they have neuropsychiatric Wilson disease in the second decade. That means more than 15 years. More than 15 years is only the Wilson disease psychiatric manifestations. Otherwise, young age less than 15 is usually liver presentation. So family
Yes.
history, previous, anybody died in the family because of jaundice, unexplained jaundice, and neuropsychiatric manifestations in somebody or say in the patient, we can think of Wilson disease.
Yes.
Okay, for me from the history, it looks like something looks to the liver pathology, which is acute. When you have acute hepatitis, infection, toxins, drug intake, Wilson's. The 4 you already put it the thing. So no drug intake, no native medication, toxin exposure. Okay, because fever is not there, I'm ruling out the infectious cause like hepatitis A, dengue, malaria, typhoid, rickettsial. I'm ruling out all because there is no fever. Okay, can you go to the examination and see is there any other further clues coming towards our diagnosis?
Yes.
Yeah.
Can it be malabsorption syndrome that can
Yes,
lead
sir.
to nutritional anemia? Can you
Yes,
think
sir.
like that line? What are the points in the history that point towards this malabsorption syndrome? Because at this age group, you can think that also as a differential diagnosis. So as Sir told, we will put the first possible diagnosis the liver problem, right? Either it may be acute on chronic hepatitis, or it may be the first presentation of chronic hepatitis that may manifest as an anemia, or it can be a simple case of nutritional anemia, as all we discussed. Okay, it may be a hemolytic anemia or nutritional anemia, or this anemia can be a manifestation of underlying hematological malignancy. So those are all the possibilities. And the final rare possibility, we can also think in line of malabsorption syndrome, considering this age group. Okay. So these are all the possibilities. So with this, we can go into university.
So, Rajal, so for my knowledge, what malabsorption presents at 49 years? Because I don't know anything like that specifically.
Yeah, celiac sprue, tropical sprue, because the patient is complaining of belching and some state.
Okay.
Sure.
Sure. Okay. Yeah, we'll go to the examination and see whether can we refine, can we narrow our diagnosis little further more.
Yes, ma'am. Proceed.
Sir, I do have a doubt, sir. Can I ask?
Yes, Arun.
Arun
Sir,
Kumar, you can
actually,
switch on and ask. Switch
sir,
on the
no.
video.
Sir, what happened is that is there any possibility of the non-immune hemolytic anemia trait manifesting itself in the later decades, sir, fourth or fifth decade? Actually, in my clinic, the net is so slow. That's why I'm not switching on the video.
That's okay. See, usually what we see in pediatric side is thalassemia, sickle cell, all present in the early age. And Bharadharan, any congenital hemolytic anemia presents at the 45 years?
Maybe enzyme deficiencies like G6PD and occult G6PD deficiency, which is precipitated by any native drug intake or other drugs, because most of the patients they will be ignorant about the drugs they have taken, sir.
So, Naina, Dr. Arun Kumar told G6PD. What's the specific history you asked for in G6PD? Deficiency presenting with acute hemolysis. What's the one more history you'll ask?
Recurrent episodes, sir.
So, based on something is precipitating, what type of hemolysis is G6PD? This is intravascular or extravascular?
Intravascular, sir.
Very good. So, intravascular, what will be the symptom? Apart from your anemia and jaundice? What is the symptom? Correct.
Hemoglobin, dark color urine, hemoglobin.
Yes. So, red color urine. And the same child comes with a red color urine, you think of intravascular hemolysis. Then you can consider G6PD precipitated by some drugs or toxins. Okay. The commonest one is very common is naphthalene balls. That's what we see in pediatrics a lot. Because in our culture, they use a lot of naphthalene balls. Naphthalene balls induce acute hemolysis if you have underlying G6PD deficiency. Clear? So intravascular hemolysis, our diagnosis changes. Here there is no history of red urine. Correct?
Yes,
So we'll go to examination.
Okay, before going to the examination, my question to hematologist Dr. Bharani. So
Yes,
we have almost forgotten the history of drug history. Patient has taken antipsychotic drugs for almost 2 years. Whether those drugs can be the culprit by causing bone marrow suppression and which can
exactly, sir.
So Naina said there is no drug.
So-
Correct, Naina? Did you say there is
drug-
no drug was given?
No,
So first
psychiatric.
of all, we should know what are all the drugs the patient has taken. So we should take the list of medications first of all, because there are some antipsychotic drugs also will cause the pancytopenias, and there are some groups like serotonin inhibitors and quetiapine. Those drugs are most commonly causing pancytopenias. So lithium or any other they have taken. That is very important, sir. Because most commonly, like we facing the pancytopenia next to the malignancies drug intake. The two that is the most common cause next to the malignancy, sir. So because we have seen half of the patients due to the simple drug, they having a land up with the pancytopenia. It looks typically like a malignancy presentation, but actually it is not a malignancy presentation. So most of the answer we get only from the proper history, and completely we have to take out the entire. And Ayurvedic, they all take homeopathic, Ayurvedic, native medications. That is the big thing, especially in eastern part of India here. People, first of all, they go to the Ayurvedic or homeopathic medication, then they will come to land up with the bone marrow failure syndromes, then bone aplastic anemias and all. So in this context, we have to always, in any case of like, while thinking of pancytopenia, patient having this, all these things, first of all, tell the patient to bring all the medications what they have taken. Individually, we have to check whether this drug will cause pancytopenia or not, because it can avoid hell lot of investigations for the patients.
Sure.
Yeah,
We'll go to examination.
So we'll go to
Yes.
examine. And I welcome Dr. Jemima. Jemima, is there any input? You are free to interrupt and discuss. Okay, ma, proceed.
Sir, general examination, patient awake, obeying all commands, moderately built and nourished, BMI 20.3, poor hygiene and self-care, not tachypnic, not dyspneic. Pallor and icterus present, bilateral pitting period edema present up to knee, no clubbing, cyanosis, lymphadenopathy, no bitoid spots, pellagra, petechiae or purpura. Local examination shows hyperpigmentation of knuckles, no tremors. Blood pressure was 130/80 mmHg in right arm supine position. Respiratory rate was 16 per minute, regular abdominothoracic. Pulse rate 130 per minute, regular rhythm, normal volume, no specific character, no delay, no venous thickening, all peripheral pulses felt equally. SpO2 96 in room air, F febrile, CBG was 140. Systemic examination, CVS, S1, S2 heard, systolic murmur, best heard in pulmonary area with no radiation or associated thrill, RS clear, CNS moves all forelimbs, tone normal, power sensory system, cerebellar functions could not be tested as the patient is not cooperative. Pupils bilateral eye, 3 mm reacting to light, plantar bilateral flexors. Abdominal examination was normal, sir. Both inspection, palpations, and auscultation. Coming to the investigations.
So,
Yeah.
Naina, so now we have an examination finding. So can you just tell what are the salient features in the examination? Right? Anemia, jaundice, what else was there?
Hyperpigmentation of knuckles, sir.
Knuckles, no lymph nodes, correct?
No lymph.
No petechiae purpura.
Yeah. No organomegalies, and only the pallor icterus and edema is there, and hyperpigment. That is the only clinical points out there. That's it.
So what are possibilities we can consider now? Now we have examination findings. So are you still thinking of hemolysis from the history?
No, sir.
Why? Anemia is there, icterus is there. Why not hemolysis?
It's an extravascular hemolysis.
Exactly. So when you have hemolysis, we'll have extramedullary hematopoiesis, you'll have hepatosplenomegaly. So that point rules out, correct?
Yes, sir.
Okay. Could it be aplastic anemia? No liver, no spleen, pallor.
Can be,
Any
sir.
possibility like that? No liver, spleen, no nodes. We always think of aplastic anemia when they don't have liver and spleen.
Yes.
But jaundice usually is not part of aplastic anemia. Jaundice is not part of aplastic anemia, correct?
Yes, correct, sir. Yeah.
Any other possibility we can think of from the history? So now we have like this classical finding, you put a picture. What is that due to? Can you
Sir,
put all the dots together now? So vegan diet, vitamin B12 deficiency. So what is the point against vitamin B12 deficiency? Hyperpigmentation, I agree. Pallor, I agree. Is jaundice part of B12 deficiency? Because the presenting complaint is jaundice.
In B12 deficiency, that is due to intramedullary hemolysis will happen, sir.
Which one? What hemolysis happens, sir? B12 deficiency, what hemolysis happens?
Ineffective erythropoiesis, which is due to
Not
intramedullary
hemolysis, ineffective erythropoiesis, correct? Because of the B12 deficiency, so the body tries to produce more and more thing that will lead to hepatosplenomegaly also. Can present, correct? Can you consider anything else now? So we have B12 deficiency, we have vegan diet, hyperpigmentation, pallor is there, jaundice, you told it can be there. Is anything we are missing, or can you straight away say it's only B12 deficiency? Any other possibilities we can think apart from B12 deficiency from the history and examination now we have?
Did any other endocrinological cause having with this presentation?
Hypothyroidism.
Why hypothyroidism? Any other endocrinological disorder having this hyperpigmentation of knuckles?
Addison's disease.
Yes.
Yeah, Addison's disease. Yeah. That is
Okay.
also one of
Any
the
other thing you think that somebody is suddenly becoming black, generalized black? Previous was very colorful with the parents. That's what children we see. A lot of things. Parents come and bring the child. கொஞ்ச நாளா என் பையன் கருப்பாயிட்டே போறான் சார். What are the possibilities you think? One is B12. Second one, we talked about, Bernice said about Addison disease. Yes, endocrine. Anything else?
Hemochromatosis, sir.
Hematochromatosis. Okay, iron overload. Iron overload. Okay. Should think of Fanconi's anemia also. Banidharan, Fanconi's anemia, typical hyperpigmentation.
Sir, usually here what we saw is Fanconi anemias. We haven't seen the initial presentation of hyperpigmentation as generally here what I have seen here, but they have like typical faces, Fanconi faces with the presentation that we easily pick up from the faces only. We have seen the presentation of the typical case, not with the hyperpigmentation, most initial presentations, sir. Fanconi.
And SLE also will think of when somebody is suddenly becoming generalized hyperpigmentation, lupus is also to be considered. But this typical hyperpigmentation on the knuckles is very classical of B12 deficiency. Putting all together, we can make a diagnosis of B12 deficiency based on this history, based on the vegan diet, pallor, typical hyperpigmentation. Only question is it purely due to diet or some other cause causing? Because Dr. Rajavel told about malabsorption. Malabsorption causing B12 deficiency. Which malabsorption usually causes B12 deficiency? Do you know any malabsorption syndromes? Somebody comes with oily stools, difficult to flush in the pan. What malabsorption is that? Oily stools. Large, bulky, oily stools, difficult to flush in the pan. What malabsorption? Very good. So which malabsorption? Correct. Which malabsorption? Fat. Correct. Fat malabsorption. Which condition leads to fat malabsorption? Huh? Which condition which can present jaundice, fat malabsorption, recurrent infections, pneumonias? Cystic fibrosis, where you can have fat malabsorption, you can have jaundice, recurrent respiratory infection. There are varied manifestations. There you can have B12 deficiency also. Malabsorption because for vitamin B12 to get absorbed, we need intrinsic factor, we need some pancreatic enzymes and all. If that is not there, can lead to fat malabsorption leading to B12, causing all the symptoms also. Okay, so that history is also important. Was this patient have anything suggestive of steatorrhea or fat malabsorption?
No, sir.
No.
As per the history.
Okay. So from the history, I can put all together. Overall, it looks like a B12 deficiency based on this typical presentation of hyperpigmentation of the knuckles. That's very classical of B12 deficiency. Any other possibilities, Barney?
Sir, actually, in this case, somewhat different because usually B12 deficiency, jaundice, usually not the initial presentation. Actually, that too, if you see, all are only 2 weeks of duration. I don't think so because jaundice with the sudden onset of the symptoms, it is like weird for B12, but it may sometimes happen. Patient may hide some of the histories behind. So usually B12 deficiency will not present with the jaundice that of acute onset actually. That is what, because otherwise patient this much of jaundice with this much of in the background of B12, patient definitely will land up have previous history of transfusion because it won't fit towards actually a B12 deficiency. He doesn't know how much B12 initially he has taken also he doesn't know, not aware of. But isolated jaundice with this picture, it's very rare for the initial B12 deficiency, sir. Yeah, that's what
I agree with that
because
B12 does not cause failure symptoms because it's a chronic, it is not acute. B12 deficiency is a chronic, our body tries to get already accommodated to anemia. They don't present like with pedal edema, breathlessness on exertion.
Exactly.
That way B12 doesn't present. Jaundice can be there in B12. We can talk about that next when you have the reports. But presentation is not classical of, apart from this symptom, yes. B12 deficiency is there, I agree. But is it all purely due to B12? We have to take it with a pinch of salt. We have to evaluate. That's what my conclusion from this examination findings.
So the only thing is we have to follow up the patient, how he is responding. That follow-up only will give us the clue where the disease status is going on. We have to finally monitor those things. Then we get the adequate, because the presentation is not usually as a classical vitamin B12 deficiency.
Yes. So now we have a confusion, Naina. It does not look like classical Pancytopenia presentation. It is not fitting into, it's really a challenging case. It doesn't fit into straight-away B12 deficiency.
Sir, I would like to add a differential diagnosis.
Yes, ma'am. Please,
Sir, I'm
ma'am.
Jemima, sir. Sir, a cause of non-immune hemolytic anemia, PNH is also a possibility in this age group, sir.
Ma'am.
It can,
Yeah.
though it can may not present always with the triad, PNH can also be taken as a differential, sir.
Sure. Paroxysmal nocturnal hemoglobinuria.
Yeah. So, Naina,
Ma'am, that is usually intravascular, ma'am.
Yeah.
Intravascular.
Ma'am, it is sir. Yeah, intravascular. But usually in this patient, the most common presentation will be the headache or abdominal pain. As such is a hemoglobinuria, but most of the patient will not have an initial presentation of hemoglobinuria. And this hemoglobinuria will always ask morning episode. It's not like evening or it's always morning. We have to ask any of the patient having the hemoglobinuria because that this acute will happen in the midnight. The complement attack exactly in the early morning. So as such, PNH is there, the name is hemoglobinuria, but most of the patient will not present with the hemoglobinuria. That is fine. That is the actual term. But ma'am has told, yeah, exactly. It is one of the DD of PNH is also we can keep, but the history is not fitting towards the PNH. As such.
So we have very really challenging case. We have various possibilities we're thinking. We thought of initial liver disease from the history and examination. We thought of B12, why B12 presenting with this. So we need more investigation to come to still more narrow the diagnosis.
How will you attribute this bilateral pedal edema up to knee to this diagnosis?
Yes.
Sir, the patient present with HP of 3, sir, because of the high of cardiac failure.
Anemia. One is anemia, yes. One is anemia because we don't know the investigation yet, but anemia can cause pitting pedal edema. Anything else in this case can cause pitting pedal edema, history-wise and examination-wise.
Yes.
Hepatitis, jaundice is there. Jaundice can lead to hypoalbuminemia, whether it's acute or chronic, or it's a chronic, can lead to hypoalbuminemia, which can lead to pitting pedal edema.
Leukoproteinemia.
Yeah, but
Both the
usually
things
they
are
have ascites, but this patient doesn't have ascites.
Yes, sir. Malnutrition, hypoproteinemia, sir.
But they
But
all
due to
okay. Yeah.
something in the cardiovascular system, there is a murmur, systolic murmur is there. So
Yes, sir.
systolic murmur along with this bilateral pitting pedal edema. So
Yes, sir.
you can think of chronic anemia. It is definitely as per the history points, it is not acute. Definitely it is not 2
Yes.
weeks duration. So duration
Exactly,
would have
sir.
been longer
Exactly, sir.
because of this pedal edema and systolic murmur. So definitely it may be a chronic anemia. As we are thinking that it is not acute anemia, it may not be due to liver cell problem and all. So something else. So as Sadish pointed out, it is a challenging case. We'll move to the investigation.
So why there is murmur, Naina? Do you know any idea why this child has got a, why this patient has got a murmur? What is that murmur due to?
Chronicity of anemia. Only in the
So
chronic
it's a anemia. It's a flow murmur. Flow murmur
Yes, sir.
due to anemia.
That's
Okay, it's a flow murmur due to anemia. They have this flow murmur. High output.
Yes.
Yeah.
Yes, sir.
So how are you going to investigate this child?
Sir, one point to note is that, Naina, shall I
Yes, sir.
intervene, sir? One point
yes.
to note is that, see, whenever you are describing a murmur, you describe it fully, be it any other case, because you have to differentiate between a flow murmur and an organic murmur. So whenever you are saying about a murmur, you describe it in full, those 7 points of murmur that we have been taught in undergraduate. And also you have to mention about the sounds and the intensity as well as any split sounds or additional sounds. Everything you have to mention. So make it.
Arun, you are not audible. Your internet is unstable.
Okay, sir, you can proceed, sir.
Yeah.
Yeah, proceed with the investigation.
Sir, coming to the investigations, at the time of admission, patient presents with 3.1, total count of 3,200, platelets was 1,18,000, sir. PCV was 9.1.
So I will do for CBC with peripheral smear, because peripheral smear is going to give a lot of importance. Apart from HP, TC platelets, we want MCV, MCHC. Whenever you have a case of anemia, that is going to give more clue. Do you have that? Yeah.
Go to peripheral.
So can you interpret that now?
Yes, sir. The peripheral smear shows dimorphic anemia, sir. Normocytic plus macrocyte, sir. Reticulocyte count was 1.8, sir. MCV was 112.
Yeah, so reticulocyte count 1.8. What does it rule out now?
It is not hemolysis, sir.
So it is not basically hemolysis, correct? So it's not, our hemolytic anemia concept has to go now. Okay, no liver spleen, retics normal, so hemolytic anemia is gone. So MCV, what's the normal MCV expect?
80 to 100, sir.
So approximately 80 to 100. So this is macrocytosis is there. Macrocytic anemia is there. MCH and MCHC. What does that give?
Sir, it is a hemoglobin concentration, sir. MCV is used to assess the size and MCHC is assess to the chromicity, sir. The amount of hemoglobin inside the RBC, sir. MCHC is more specific, sir, than MCH, sir.
Sure. So why do you do DCT for this patient? What's the idea of doing DCT?
For autoimmune hemolytic anemia.
Okay, again, retics has to be high. Okay, retics has to be high, not very rarely only we can have low retics, but usually DCT will be positive if you have retics has to be high. Okay, what is the LFT showed? So here we know that the child has got low hemoglobin, low white cell count, platelets borderline, correct? 1.17 you said. Differential count is okay? Anything to suggest your malignancy?
No, sir.
Okay, it all looks okay, correct? Sure.
So I can intervene in this, sir. I can intervene in some of this.
Please, Bhavin.
Yeah. So what is the cutoff of anemia for hemoglobin, WBC, and platelets? So what is the definition for pancytopenia?
Sir, it's the total count should be less than 4,000, sir.
Okay.
Platelet should be less than 1 lakh, sir.
Okay. And the
HP less
hemoglobin?
than. Sir, according to the ages, in Pancytopenia, it's 9, sir.
So generally the concept is, according to the WHO or the textbook thing, usually the anemia for adult. So whenever you're interpreting the hemoglobin, you have to see the age group of the patient, because for pediatric group it is very different. For infants, adolescents, and adult is all different actually. If you take the patient as adult, so you keep it as 13.5 in the case of male and 13 in case of the female. That is the anemia. And second is, as you know, TLC, it is less than 4,000, and platelet 1.5 lakh or 1 lakh. It always have a confusion. So better you always take it as 1 lakh, because after 1 lakh plus or minus, it nothing difference will make. So always take it as a 1 lakh, and hemoglobin of 13 in the context of age group, and TLC is 4,000 actually. That is the usual cutoff we generally practice in the hematology. Yeah. So 1 to 1.5 lakh is the plus or minus. We cannot completely say it is a pancytopenia. Okay. And always, as sir has mentioned, the differential is very important, whether it is a lymphocytic predominant or monocytic or predominant, because sometimes in bone marrow failure, you will see predominantly the lymphocytes will be elevated. That is one thing. As such, here I cannot find any of the main point. It is not fitting toward any of the malignancies. In the case of acute leukemia, definitely the platelet will not be more than 1 lakh. It always less than 50,000 or 30,000. Sometimes 10,000 will be there. Okay, and that is one thing. So from the major predominantly part is, I can see only the hemoglobin which is drastically reduced when compared to the other two cell lines. Okay, so that's what from the investigation we can see. And make sure always see the entire picture of the CPC. Look the graph also. From the graph and from the what you got the printed version, like from your machine, that we can completely interpret easily for those things. And see MCV, MCH, MCHC, right? For example, in this scenario, if MCHC is more, like if you see the, well, what is the importance of MCHC in this scenario?
Hypochromic.
For example, if the MCHC is 40, 45, 55 is there, in the aspect of pancytopenia, what you will think of? And second part, MCV is 140, 150. In this case, suppose this patient have this type of presentation, the MCV is 130, 135, 140, because the B12 deficiency will not have the MCV more than 130. Is there any agglutination? Because some of the lymphomas will present as this autoimmune cause, like agglutination will be there. So in those things, we have to rule out from the peripheral smears. And MCHC, because of the big RBC, agglutination RBC, the machine will count the big RBC as a single cell. Automatically, there will be the discordance between the MCHC and MCV. So that is very important. Okay, so this is most important thing you have to interpret. So mostly the MCV of more than 130, 140, it will not definitely fit into the B12 deficiency. Usually in B12 deficiency, the MCV should be more than 120. In 100 and 110 is the plus or minus will be there, right? Yeah. And second thing is that reticulocyte count, it is 1.8%. Always interpret corrected reticulocyte count rather than a single reticulocyte count. Always you correct the reticulocyte with the hematocrit of the patient. That is very important. For example, there is an anemia. If the CRC comes 1%, 0.5%, and the machine counts as 4%, so we are wrongly interpreting the disease. So always interpret the corrected reticulocyte count while interpreting the entire thing, because the single, in any case of anemia, the reticulocyte count gives the entire picture. We can entirely classify the disorders based upon a single reticulocyte count. So if you order one investigation for anemia, the best investigation is reticulocyte count. So as such, in hematology, reticulocyte count is the ECG for hematology. Because why? It entirely classifies hypoproliferative or hyperproliferative. Because the disease, there are some disease which is more common in hyperproliferative that entirely classifies the entire disease spectrum. So the main important part is reticulocyte count. That too, a corrected reticulocyte count according to the hematocrit of the patient. That is very important.
So, Naila, do you know, as Bharanidharan said, how do you do corrected reticulocyte count? For example, for the same patient, the reticulocyte counts has come as 8. Okay, assuming it is 8, what is the correct? How do you do the corrected reticulocyte count? Hemoglobin is 3, or PCV you said is 9. What will be the corrected reticulocyte count? Reticulocyte count is 8 for this patient. What's the formula? What's the formula to correct the correct? Because Bharanidharan was talking about corrected reticulocyte corrected. How do you correct? 8 is the reticulocyte count. So do you know the formula? So observed expected PCV minus observed PCV into this reticulocyte count. Okay, so we are what's the expected PCV?
So we always keep the
yeah.
Yes, sir. Actually, we always keep the cutoff of 45. Generally,
45.
as per the textbook, for male it is 45, for female it is 42. But usually we always take it as a 45. Reticulocyte count into patient hematocrit divided by the control, right? That is the usual reticulocyte. As there was one different
this shall
type
be
of
9 by
formula.
45.
Yeah.
Suppose 9 is the PCB. So 9 by 45. So 9 is observed by expected 45 into reticulocyte count. I said 8. Assuming it is 8. Understand? So 9 by 45 into 8. That will give you the corrected reticulocyte count. If that is more than 2, it's suggestive of hemolysis, or the bone marrow's protection is more. Okay. This cell is 1 point. It is already less than 2. So it's not significant. Suppose it comes as 8. Don't think, oh, 8 is there. That means hemolysis is going on. Go for the corrected reticulocyte count.
Yes.
Okay. Next one. What investigation we have for LFT?
Move to further investigation and present the final diagnosis.
Yeah. So now what is the first LFT showed? Can you interpret that LFT for us?
The patient has a total bilirubin of 7 with predominant indirect bilirubin, sir.
Indirect or direct? Indirect or direct? 7 and 2.8. Is conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia?
Unconjugated hyperbilirubinemia, sir.
What's the definition of unconjugated hyperbilirubinemia? What's the definition of unconjugated hyperbilirubinemia? If the direct bilirubin is more than 2, sorry, if the direct bilirubin is more than 1 or more than 20% of the total, correct? That's called direct. So this is 7 and 2.8. So 3 you keep. It is more than 20% or not?
Yes, sir.
Yes, that means it's conjugated. Understand? So it is the definition for conjugated bilirubin is if the direct bilirubin is more than 1 or more than 20% of the total bilirubin. It is almost 40%, correct? It is almost 3, 7 and 3. So it will become like a conjugated hyperbilirubinemia. Yeah. Sure. Liver enzymes are elevated, correct?
Okay. With OT more than PT, sir.
Okay.
If there is any age reversal, so in the context of pancytopenia, you are seeing the age reversal, right? So in hematological aspect, what you will think of?
Multiple myeloma.
Yes.
Multiple myeloma, sir.
Yeah, it's a plasma cell dyscrasias. Okay, that is also one of the things you have to look, because some plasma cell dyscrasia also have an initial presentation of pancytopenia, right? That is the one thing.
Or immune hyperactivation. Your immunoglobulins are going to be high. If you take in SLE patients, the immunoglobulins are going to be elevated. In any immune dysregulation, immunoglobulins are going to be high. Your total globulin will be high. That means indirectly saying immunoglobulin is high. That is, you are telling plasma dyscrasis. Your immune system is more active. That's what we usually should take it. Okay. So that part is okay. 5.8 and 3.2, that is okay. So he has got conjugated hyperbilirubinemia with elevated liver enzymes. See, it looks like some liver pathology is going on. It looks like some liver pathology also is going on.
PT is OT is more than PT, sir.
What does that give a clue? Because this is the second time you're telling me the same thing. Sir, OT is more than PT. So what does it give a clue?
Sir, PT is more liver specific, sir.
Sorry, so SUOT high means?
Other
Like what?
causes.
Like muscle. You think of muscle. OTPT is a muscle enzyme. The liver, but TPDB won't be elevated, but it's a muscle involvement. We see in inflammatory myositis, you will see the SGOT and SCPT will be elevated, but SGOT will be more elevated. So we have 4 muscle enzymes, correct? SGOT, SCPT, LDH, and CPK. SGOT says it is muscle, or if it is a purely a liver pathology, Wilson disease will have more SGOT than SCPT. That's a clue. When somebody presents with chronic liver disease, and if you see the SGOT is more than SCPT with conjugated hyperbilirubinemia, I will think of Wilson disease as a diagnosis. Okay, sure. So he has got conjugated bilirubinemia with the liver enzymes elevated. Then what happened?
Sir, we proceeded with the serum LDH.
LDH.
Yes, sir.
Okay, that is high. What does that give a clue?
Sir, LDH is increased, sir.
So what does it give a clue?
There is some hemolysis going on.
So LDH again non-specific marker. Malignancy it will be elevated. Hemolysis it will be elevated. Muscle disease it will be elevated. So LDH is like one ESR. Something is wrong, I can say. It is not specific for hemolysis. It is not specific for anything. Okay, hemolysis also it will be elevated, but this child doesn't have hemolysis. Retics is normal. And the bilirubin is unconjugated hyperbilirubinemia. Sorry, conjugated hyperbilirubinemia.
Yes.
Sure. Next. Peripheral smear we discussed. Then coagulopathy. Is it normal or abnormal?
Sir, PT is elevated, sir. And INR is also mildly elevated, sir.
So what does it give a clue?
Sir, vitamin K deficiencies, as the patient is already has nutritional deficiencies.
So some hepatitis is there. Some hepatitis is there. That's the reason your VADEK, your vitamin K is low. Yes. That is leading to prolonged INR.
Yes, sir.
Okay, some liver pathology. Then now we are coming back to some liver pathology is there. Hepatitis is there. Conjugated hyperbilirubinemia, elevated liver enzymes, and your INR is slightly prolonged. Okay, next.
So can I intervene once?
Yeah, please.
Yeah, for example, if you see a pancytopenia with deranged parameter like PT is elevated, APTT is elevated, and you add fibrin version also, it is very low. So what you will think? You are receiving the patient in ER. You are seeing that there is a pancytopenia with deranged coagulation parameter. What you will think of? What you have to do first? First thing you inform to the pathologist to look for any promyelocytes in the peripheral smear or not, actually. Sometimes acute promyelocytic leukemia will present with this pancytopenia with deranged coagulation parameter, because APML is the hematological emergency. If you intervene very fast, you can save the life of the patient. It is a 100% curable malignancy, right? So we have to start a ATO/ATRA. So whenever in the context of pancytopenia with deranged coagulation parameter, make sure to check for peripheral smear atypical promyelocytes. That is very important. Yeah, next.
Okay, so what is this showed? So ferritin is low, iron is okay, total iron capacity is also okay. Ceruloplasmin you did, it is 40.
Yes, sir.
B12 has come as low, correct?
Yes, sir. Both methyl malonic acid and homocysteine also is elevated, sir.
So how do you interpret all this report? So B12 deficiency is there, correct?
Yes, sir. It's a vitamin B12 deficiency with ineffective erythropoiesis.
So ineffective erythropoiesis. So your diagnosis is going to be? based on these results?
Megaloblastic and
Megaloblastic anemia due to B12 deficiency.
deficiencies.
Okay. Are you missing anything, or that's going to be the final diagnosis? Because we said some lot of odd points for plain B12 deficiency. What is that, Ra?
Read further investigation after bone marrow.
Yeah. So you did a bone marrow also.
Yeah,
Yes, sir.
read that
So blood
also.
tests. Yeah.
Sir,
So chest X-ray
USG
normal,
abdomen-
sinus. Yeah.
Yes, sir. USG abdomen and pelvis shows mild hepatomegaly, sir. Both urine culture and blood culture shows no pathogen. Chest X-ray was normal. ECG shows sinus tachycardia. TROP-T was negative. CKB was 23. TFT was normal, sir. Ophthalmology opinion was obtained. There was no KF ring was present. Cardiology opinion, normal echo study. INCI opinion, the patient was not willing for ogidoscopy and colonoscopy. HIV, hepatitis is antigen negative. ICTC, HCV and ICTC was negative. Urine routine examination, normal study. Urine bile salts and bile pigments negative. Urine neurobilinogen negative. Urine for H2 negative. CT abdomen and pelvis, normal studies. Bone marrow aspiration report shows erythroid hyperplasia showing micronormoblast with megaloblastic type of maturation, sir.
So, Naina, so you have done so many workup because you are not very happy with the plain B12 deficiency. Is that correct?
Yes, sir.
Correct?
Yes, sir.
We've done a lot of tests now, CT abdomen, because if you suspect plain, because that's what we are discussing. This child is not a straightforward case of B12 deficiency. B12 deficiency is there, but is there anything else? That's the reason you did all your HIV, HbA1c markers, Wilson's disease workup you have done. We've done a CT abdomen and chest to look for any malignancy. Finally, bone marrow is showing megaloblastic anemia. So megaloblastic anemia is there. But there are a lot of odd things in the history and in the examination. Presenting only with jaundice, having pedal edema, exertional dyspnea, hemoglobin of 3 can happen in B12 deficiency, but usually they don't go for failure symptoms. That was we are discussing. These are odd points in your patient.
What about bone marrow biopsy?
Not done, I think so.
No, sir. Aspiration only we did, sir.
So why the bone marrow biopsy is very important, because in sometimes the lymphomas usually cannot pick up only by the aspirate. The patchy infiltration seen only in the bone marrow biopsy. So in any case of pancytopenia, always bone marrow biopsy is important to rule out the lymphoma, low-grade lymphoma involvement. Sometimes the low-grade only in the bone marrow will be there. So we are missing the entire pathology. So the bone marrow biopsy is most important in the whatever you are doing, any invasive procedures. Always make sure to take both aspirate and biopsy. So here we doesn't know what exactly in the biopsy. Sometimes hemoparasites will be residing in the bone marrow biopsy. We cannot pick up by the aspirates. So that is also very important in the context of this patient, actually. Yeah.
So what did you do for this patient? So we done extensive workup, which all came as negative. So only megaloblastic anemia is your diagnosis. What did you do with this patient?
Go to course of the patient.
Sir, course in the hospital, sir.
Sir,
49-year-old male patient present with complaints of yellowish discoloration of eyes, breathlessness for 2 weeks. Baseline hematological and biochemical investigations were sent. In view of a pallor with icterus and tachycardia, initial clinical impression was anemia with possible hemolysis. Initial laboratory investigations revealed pancytopenia with elevated LDH. Proceeded with peripheral smear, which showed dimorphic anemia with normal red count with no schistocytes. Iron studies were normal. Proceeded with direct and indirect Coombs tests, which were negative. Viral serology was negative. Serum ceruloplasmin was within normal limits. Ultrasound abdomen shows mild hepatomegaly. CT abdomen did not reveal any significant abnormality. Ophthalmology opinion did not show any KF ring. Cardiology evaluation was also normal. Considering macrocytosis on smear and clinical suspicion of vitamin B12
were assessed and found to be low. Serum methyl malonic acid and homocysteine levels were detected. Bone marrow which showed these findings confirmed that megaloblastic anemia. Worked up for the causes of megaloblastic anemia, and the cause was found to be cobalamin deficiency. After confirmation of vitamin B12 deficiency, the patient was started on parenteral vitamin B12. Supportive care was continued along with folate. Supportive care was continued with monitoring of vitals and hematological parameters. Over the course of the hospital, patient showed symptomatic improvement. The patient was counseled regarding dietary modifications and the importance of compliance with the same. Gastroenterology opinion was obtained. The endoscopic evaluation was advised, but patient was not willing for further invasive investigations. The patient was discharged with advice to continue vitamin B12 supplementation and follow-up for reassessments.
So how do you assess a response for B12? How you assess a response in this patient?
Sir,
Whether
the
B12
patient will
is working or not?
So Naina, your patient B12 worked,
Sir, the
so you
patient-
gave B12. Did the hemoglobin improve? All the counts improved? Jaundice resolved?
Yes, sir. The patient improved, sir.
Patient improved, the hemoglobin all improved.
Listen. Yes,
White
sir.
cell count, platelets improved,
Yes, sir.
and the
Yes, sir.
LFT normalized.
Yes, sir. Oh, by the discharge time itself, it's started showing.
Okay. So why I asked the question? Because there are some oddities we talked about. This conjugated hyperbulimia is usually not part of B12 deficiency. Rarely it is reported. Conjugated hyperbulimia also can cause B12 can cause some amount of cholestasis. If the child improves with all, B12 has completely become normal, I will not do any further test. If the B12 is not going to help, the patient is still symptomatic, the hemoglobin is not come up, platelets are not come up, I think if the liver is still the liver enzymes are still high and conjugated bulimia is there, she needs further evaluation, further liver pathology. If B12 is settled, I'm very happy. So it's like a atypical presentation of B12 deficiency because it responded well to B12 treatment alone. I'm very happy with that.
So even the jaundice, even in the jaundice in the context of B12 deficiency, always have unconjugated hyperbilirubinemia rather than a conjugated hyperbilirubinemia. As sir has already mentioned, there is some liver pathologies going on in the background of vitamin B12. So we have to further follow up the patient what exactly the other things. So it is somewhat odd from the B12 deficiency. Yes.
So I feel this case is nicely worked up, Rajavel.
Yeah.
We have got a lot of interesting atypical presentation. And
because of the atypical presentation, starting from icterus and
yes.
exertional serious cardiological problem, pedal edema. So we wanted to rule out everything in our mind.
Exactly.
Hematological malignancy, liver cell pathology. So all were ruled out by extensive investigation. So finally, we branded the case as a B12 deficiency. And moreover, the patient started showing improvement with the B12 supplementation.
Yes,
but
that's what important. That's what important. Therapy worked.
Still, we have a suspicion of liver cell pathology. As Dr. Bharani opined that we have to follow up the case with even the colonoscopy or follow up liver enzymes in estimation, and then follow up liver scan. Then those can be done in future to rule out the evolving liver cell pathology. So that will be the summary of this case.
Yeah.
Yes. So, for example, in this context, in pancytopenia, you are seeing the high vitamin B12 levels. Now, what you will think of? Pancytopenia with high vitamin B12 levels. So, you are having in the OPD patient taking all the investigations. In that, you are seeing this vitamin B12 is high. If you see this thing, what you will think in next?
Dysplasia.
So always rule out the malignancies because some of the malignant cells will express the transcobalamin 2 receptors. Usually in B12, the machine will analyze how much TC2 receptors are expressed. So the abnormal cells will express more number of transcobalamin 2 receptors. So that indirectly gives a high elevated vitamin B12. So the pancytopenia with a high vitamin B12 always rule out the malignancy. So that is most important aspect. You don't need to or any other investigation. Just directly do your bone marrow and refer the patient for malignancy center. It is the simple thing. You can avoid all the investigations. And whenever the case of pancytopenia comes, simple thing: do CBC and do reticulocyte count. That's it. And the most common cause in India is vitamin B12. Only these three things. You can find out, you can classify all sort of disorders. Bone marrow is only for confirmation. It is not for diagnostic in the case of pancytopenia. So this is one clinical aspect you have to intervene first. Yeah. And pancytopenia with deranged coagulation parameter, always think of, in hematological point of view, rule out APML. Because it is a life-saving malignancies, you can save the patient. If the patient getting bleed, you cannot save the patient. That too in the very younger age, patient is 25, 28 year, 32 year, they present with these manifestations. That too is very important. Okay. Yeah.
Thank you, Barney.
Thank you, Naina.
Any other queries can be raised by postgraduate? If no queries, we will wind up the session. Queries are welcome from the postgraduates to hematologists and rheumatologists.
I have to present some take-home messages from the practical aspects of pancytopenia. Just 3 slides I just want to emphasize.
Please
so I will share my slides. Can you please just...
Naina, stop sharing. Yeah.
Yes, sir. Can I start sharing, sir? I cannot do that.
Naina, please stop sharing so that Dr. Barnidharan will take over.
Is it done? I cannot.
Dr. Naina,
I cannot.
Host, please stop sharing. Yeah, right. You are free to share.
Yeah, yes, sir. Yeah. So whenever you're evaluating the pancytopenia, always ask only 3 questions. Is the marrow is failing, or ineffective hematopoiesis, or marrow infiltrated by the marrow infiltration? That is only the 3 questions you have to ask. You will find out most of the answers. So I will share the presentation after completing this. These are all the most common mechanisms and causes. And most common cause, like in India, in hematological aspect of view, megaloblastic anemia and myelodysplastic syndrome, aplastic acute leukemia, hypersplenism. And these are the 12 clinical history questions always in the case of pancytopenia you have to ask. And most important point, these are smear findings you find out in these are all the entire morphological clue you can fit into direct diagnosis of whatever in the case of pancytopenia. So always see the MCV, reticulocyte count, WBC differential, MPV. What is the importance of MPV? If it is MPV is high, that means it indicates there is a peripheral destructions. So you can easily rule out the diseases or etiologies of pancytopenia and LDH. These are the 5 parameters whenever you have having the case of pancytopenia. And yeah, sometimes this severe vitamin B12 deficiency can mimic as a pseudo TTP syndrome. In that scenario, as you already they have done an investigation ADAM TS13 activity. In TTP, it will be very low. It will be a normal. So the key differentiating factor is most important point is that reticulocyte count and this ADAM TS, because the TTP also have a similar manifestation of the severe vitamin B12 deficiency. So these are all some of the take-home messages. Always exclude the dilutional cytopenias, some lab errors or pseudo-thrombocytopenias, and detailed clinical history is very important. And one simple thing is see a peripheral smear and MCV and splenomegaly and reticulocyte count. This is a simple test you can do for any case of pancytopenia. From this investigation, you can find all sorts of pathology. Always rule the infections like HIV, tuberculosis, parvovirus, Kala-Hazar, and dengue. In the endemic areas, the Kala-Hazar in the part of Bihar, those areas. So always infection is the most important because bone marrow suppression, second most common cause of pancytopenia, and drug history and native medication. That is the most important history among all other important history. And the common drugs like linezolid, ceftriaxone, methotrexate, anti-epileptics like phenytoin and valproate, and codeine. These are all the most common drugs which we usually encounter in the context of pancytopenia. And DCT negative, hemolysis, pancytopenia, and thrombosis at unusual sites. Always see for peroxisomal nocturnal hemoglobinuria, as Dr. Jimam has already informed. And second thing, pancytopenia with high vitamin B12 levels. Always wrote the clonal disorders. There is 100% the patient will have a malignancies. So this is an important point. And second, the most is bone marrow aspirate procedure is not required. Pancytopenia is it only for the confirmation. And second thing, always SLE, autoimmune etiology, you have to rule out. And sometimes severe vitamin B12 deficiency mimic a pseudothrombotic microangiopathy. In that scenario, the same schistocytes will be there in the peripheral smear. In the case of severe vitamin B12 deficiency anemia, sometimes a sickle-looking like cells also will be seen in the peripheral smear in the case of severe vitamin B12 deficiency. So that is also very important. And second thing is aplastic anemia versus hypocellular MDS. This also have a distinctions, but usually dysplasia. If cell is looking somewhat abnormal of any cytogenetics or any other abnormalities, that is a main differentiating feature. And second point, PNH clones always coexisting with the aplastic anemia. So always rule out the any PNH clone because PNH as such the disease is peroxisomal nocturnal hemoglobinuria. The patient will definitely not present with all these features. Some may be a small minor clone will be there. So always remember PNH will not present with the classical triad. And second thing, pancytopenia with a massive splenomegaly along with the monocytopenia. Always look for hairy cells. That is also one of the differential diagnosis. So always check in India like vitamin B12, folate, reticulocyte count, PS before proceeding for the marrow. And transient cytopenia may occur due to the infection or drugs. So if you're receiving the pancytopenia, rule out the infection, drugs, and wait for 1 week, and you can call, then the patient, the automatic recovery will be there. So all these infections will also cause a transient suppression of the bone marrows. And second is always classify the anemia by looking at the MCV first, and severe anemia and macrocytosis, always think megaloblastic anemia. So reticulocyte count is the ECG of hematology. So it classifies either hypo or hyper proliferative anemia. And second things in B12 deficiency, psychiatric symptoms may precede anemia sometimes, even before the anemia manifested. That is important. Always check the day 7 of vitamin B12 treatment, because at that time the hemoglobin also will get improved. The reticulocyte also have a high reticulocyte count will be there. So always check the day 7 of the vitamin B12 treatment so that you can assess the response. For example, if there is a no response to the day 7, so always rule out any other bone marrow disorders is there for the patients. So always the response is more important rather than the treating the patients. You have to see the response. That is very important. Sometimes B12 deficiency may be a part of autoimmune polyglandular syndrome. There may be some other associated etiology will also will be there. You cannot completely rule out or completely relax. Okay, this patient is having B12 deficiency, we have treated. So always remember the follow-up in any case of nutrition deficiency, always we have to follow up the patient. That is very important. And most important thing it is, if you're suspecting the MDS, always rule out the vitamin B12 deficiency before diagnosing the MDS, and most commonly sepsis. If nothing is there, there is no neutrophil, patient might land up in a septic shock. So that is the most common reversible cause of pancytopenia in the ICU. So this is what take-home messages for pancytopenia. I think these are all the things which I have seen for the past years, and someone can add up from their experiences.
Yeah, sure. So, Naina, so what's the learning point I want to tell is, in the exam, don't present towards a final diagnosis, even if you know. From the history and examination, there's nothing to suggest pancytopenia in this child. So examiner, don't present towards pancytopenia, because the exam is mainly to see how you are approaching this child than making the final diagnosis and treating. So this case was kept for your exam. You just present like what we discussed, because it's not a straightforward case. We have to discuss this could be that, this could be this, hemolytic anemia, primary liver pathology, B12 deficiency, but there are some atypical features for a classical B12 deficiency. We have to discuss. Than making, oh, this is a cancer of pancytopenia due to B12 deficiency. Don't present like that in the exam. Because the exam, we want only your thought process and syndromic approach to the patient. Okay.
Yes.
All the best, Naina. Good presentation. Thank you very much.
Thank you.
Yes, thank you, Dr. Satish Kumar, Dr. Bharanidharan, and Dr. Jemima. Any input, Dr. Jemima?
No,
Yes.
sir. No, sir.
Okay. So thank you. It is a invited discussion very well. And especially the points, there is a take-home messages from Dr. Bharanidharan. The last 3 slides were awesome. It is very much useful for and informative for the PGs. So it's a very good, fruitful discussion for PGs. So PGs, don't take a case of pancytopenia as light as possible, because a pancytopenia is not as easy as we all thinking. It invites lot of workup, lot of your cognitive thinking, lot of your skills for the diagnosis. So with this, we are winding up the session. Arun, are you there? Want to add anything?
No, sir. No, sir.
Well, it was-
I just want to thank the experts, sir. Thank you, sir.
Yeah. So, right. So I wholeheartedly thank my friend, close friend, Dr. Satish Kumar, for giving more and more inputs towards this case. And thank you very much, Dr. Bharani. I am proud of you,
Thank you, sir.
because you are alumni of our college. So alumni
Thank
of
you,
our
sir.
college has reached this much of heights and able to
you,
discuss
sir.
a case in a very
Thank
elite
you, sir.
manner. I'm proud of you.
Thank
He
you,
is a role model for all of the PGs of
Yes, sir.
Thoothukudi Medical College. So thank you, Dr. Satish, Dr. Bharani, and Dr. Jemima.
Thank you, sir.
So thank you all. Thank you, PGs, for your patient listening and good presentation. Naina, thank you. Special thanks to you. You are presented well, and you have taken the brunt of the attack, especially the questions from legends like Dr. Satish and Dr. Bharani, and you are able to answer most of the questions. I am proud of you. It's a very good presentation and very good preparation also. So thank you, one and all, and we'll meet in the future webinars. Thank you.
Yeah,
We'll
thank
close
you.
it.
Thank you very much. Thanks.
Thank you, sir. Thank you.
Thank you, sir. Thank you.